Alright, Treadwell DPT back with another anatomy breakdown, muscle by muscle. And they were talking about a small but mighty member of the rotator cuff, Teres Minor, the baby. Easy to overlook, small muscle, not flashy. If you care about shoulder stability, external rotation, and keeping people pain-free, you've got to know this one. So let's break it down. Origin, insertion, innervation, function, and of course some clinical nuggets. Teres Minor sits right below the impingement on the posterior scapula, running from the lateral border of the scapula to the greater tubercle of the humerus. The name being two parts, teres meaning rounded, and minor indicating that it's the smaller of two similar muscles, the other being teres major. That being the case, I'd still say it's more similar to infraspinatus. Basically, infraspinatus' little sidekick, in a way. They're right next to each other, same primary action, similar orientation, but just a little guy, a little small muscle. Like the rest of the rotator cuff, plays a big role in keeping that humeral head centered and keeping that shoulder joint stable. If you feel like you've heard that before, you're starting to get it. So our origin is going to be that superior half of the lateral border of the scapula. Of course, posteriorly, we're going to be right below that infraspinatus. It runs laterally and inserts on the inferior facet of the greater tubercle of the humerus. If we look at the arrangement here, we've got our three posterior rotator cuff muscles in order, from superior to inferior. Supraspinatus sitting on the top, being the most superior muscle of the group. Infraspinatus in the middle, right below that scapular spine. And then little teres minor sitting right below that infraspinatus. Looking at this image here, you can really see how fitting that rotator cuff name is. Cuff really being a term we'd use to reference like a part of a sleeve or glove. We can see how all these tendons interact with the surrounding fascia, make like a little glove around the humeral head. So it's nice to just look at the anatomy here, and seeing it helps appreciate how the rotator cuff muscles play such a big role in more of those fine motor, fine tuning stability movements of the little humeral or shoulder joint, right? Pretty cool stuff. Anatomy is easy if you let it be. Function-wise, it's all about that external rotation and shoulder stability. Also has a slight role in adduction, but we will say that primary role of teres minor is going to be that external rotation. We mentioned in the last video, we've got studies that have shown infraspinatus is responsible for about 75% of that external rotation torque, which leaves only about 25% for teres minor. But to that point, we also know that infraspinatus is much more active in the adducted shoulder position, whereas teres minor picks up the slack as we abduct our arm. Teres minor has been shown to be really important in patients with rotator cuff tears. In patients with supraspinatus and infraspinatus tendon tears, teres minor ends up providing much greater force to counteract that subscapularis on the front. As a result of that increased activity, we'll often see hypertrophy of the teres minor muscle belly in those rotator cuff tear patients. So even though it's small, it'll still play a very important role in our shoulder stability, no matter the circumstance. Another important note is that teres minor is innervated by the axillary nerve, not the suprascapular nerve like those other posterior scap muscles. So sharing that innervation with the deltoid, nerve roots are going to be C5 and C6. Teres minor is innervated by the axillary nerve roots C5 and C6. The axillary nerve wraps around that surgical neck of the humerus, so again, it can be vulnerable to injury with fractures or shoulder dislocations. That's something we do want to keep in mind clinically. To that point, teres minor tears are fairly uncommon compared to other rotator cuff injuries, but the innervation injuries occur a bit more frequently. Teres minor acts as the superior border of an anatomical space called the quadrilateral space, which is where the axillary nerve and the posterior humeral circumflex artery pass through. This is a relatively vulnerable area, and axillary nerve compression through this area could lead to the loss of teres minor function. A good test for teres minor strain and function would be what we call the Hornblower's test, or Hornblower sign. We know that the infraspinatus produces the most external rotation torque at 0 degrees of abduction, so directly adducted. As we increase our shoulder abduction angle, we bias the teres minor and the posterior delt, but primarily we're looking at that teres minor. We've got research that says at 90 degrees of shoulder elevation or abduction, the teres minor actually produces the largest external rotation moment. So for the Hornblower sign, we move our arm up to 90 degrees abduction, 90 degrees elbow flexion. We've got the forearm parallel to the floor, and we'll ask the patient to externally rotate the shoulder against resistance. We know that if it's weak or painful from that position, something's up with the teres minor. So there we have it, teres minor. A little buddy, posterior, external rotator, and big time stabilizer. Unsung hero. It'll step up if it needs to. Not as talked about as supraspinatus or infraspinatus, but definitely still crucial, especially in those high level rehab cases or when we're dealing with massive rotator cuff injuries. Next up, we're going to finish off the rotator cuff muscles with subscapularis, our only internal rotator of the group. It'll be a good one for sure, so if you're feeling the breakdowns, hit that subscribe button and follow along for the full series. We're gonna hit every muscle, so tag along for the ride. Pedal DPT, we did it again, another one. Catch you next time.